Hello, everybody, and welcome to this Health Foundation webinar. I'm Anita Charlesworth, and I'm an economist here at the Health Foundation. The webinar is part of our work programme for the Commission for Healthier Working Lives, which is being supported by us here at the Health Foundation. And today we're very excited to be exploring how employers and government policies in other countries have worked to address some of the challenges around ill health as a barrier to work, with the aim not of lifting and dropping, but challenging our thinking and providing some ideas for us to consider within the UK. The Commission has been looking at the trends in the UK's working age population and their implications for the labour market, and is moving now to think about what we might do for that. And so these insights into the experience of other countries are going to be particularly beneficial. Just some housekeeping from me. Um, we are recording this webinar, as you will have heard, and the recording will be available on the website within 24 hours, and then there will be a subtitled version shortly thereafter. The aim here is to have an interactive webinar, and so we'd really like you to start thinking about questions that you'd like to ask our amazing panelists today. On your screen in Zoom, you should see at the bottom a Q&A box. If you could please add any questions into there, and if someone else has asked what you consider to be the question, then you don't have to retype in yourself. You can upvote that, and we will aim to prioritise both a broad range of questions, but also those which are particularly popular. And Sam Atwell, our colleague from the Commission, will also be on hand to answer any factual questions that you might have as we go along. For any of you that are active on social media and like to post as we go, today's hashtag is hashtag healthier working lives. So I am delighted today to be joined by four fantastic panelists. So we have, sorry, we're going to start with a presentation on some new analysis for the Commission from Johnny Gifford, who is Principal Research Fellow at the Institute for Employment Studies. After Johnny's presentation, then we're going to move straight into some reflections and insights from our three other panelists, and that is Christopher Prince, who is from the OECD, Sarah Cunningham, Managing Director of World Wellbeing Movement based in Ireland, and Marta van Vilsteren, Senior Knowledge Advisor at the Dutch Employee Insurance Agency. And I'll tell you a bit more about each of them as we come to them. So this isn't a memory test. So first of all, what I'd like to do then is to introduce Johnny Gifford. Johnny is from the Institute for Employment Studies, and he's going to be talking us through some new research which the Institute have done and he has led for the Commission, which we published today on the website, and please do take a look at the research report. Johnny has been conducting applied research in people management organisations and HR for over 20 years, and I won't list all the different roles he's played to do that. His work interests include job quality and good work, and change within organisations, all issues which are really, really important to the health and work agenda. So thank you very much. Johnny's going to have some slides and talk to us. And as he's talking, do use the Q&A and get those questions started. Over to you, Johnny.
Thank you very much, Anita. So let me just share my screen and then I will be off. Okay. So for those of you who don't know IES, we are an independent centre for applied research. We were founded in 1968. We're about 60 staff, and we do research into labour markets, employment and skills policy, and also HR and people management. And our work is funded by research foundations and a range of government body and employer clients. And you see some of those here. The research that we're launching today, as has already been said, supports the Commission for Healthier Working Lives. It's available on the IES website, and we're very grateful to the Health Foundation for funding the work, and also to our partners at the Learning and Work Institute for their support. We started out by looking at two research questions. So first of all, how does the UK differ from comparable countries in terms of the prevalence of ill health and also the likelihood that ill health leads to worklessness or economic inactivity? And secondly, we wanted to review some of the interventions that exist overseas to think about what potentially might the UK learn from. In our statistical analysis, we're focusing on the EU 15. So that's the members of the EU up to the 2004 expansion. And we're doing that because of both data availability and to focus on the countries that we think are most similar to the UK. So we've got two parts to the research. First of all, we're doing that analysis of EU 15 data, and we're doing that pre and post pandemic to see how that's changed. 2022 is the most recent data that we've got for this. We're using the EU Silk as our main source. And because the UK is not part of that data set post Brexit, for the 2022 data, we matched data to the Understanding Society survey. And what I'm going to do now is to give an overview of the statistical analysis that we've done, and hopefully we'll be able to discuss that second part of some of the different national approaches afterwards. So looking at the basic numbers, first of all, this is kind of like the raw data. You can see that the UK is towards the upper end of reported chronic health conditions. So this graph shows that 21% of the working age population in the UK has long-term ill health, compared to 17% for the EU 15 overall. And when we look at the employment outcomes of these people with ill health, we find that across the board, or almost across the board in the EU 15, they became less likely to be employed or in work through the pandemic, so comparing 2018 with 2020. And that drop in employment rate was bigger in some countries, including the UK. One of the really important comparisons to make is in the work outcomes of people who are generally in good health compared to those with chronic ill health. So what you see in this graph, if you look at the UK in orange, you can see that we've got one of the highest employment rates among those who've got good health, but we've got one of the lower rates for people with ill health. And what we center on in our analysis is the gap between these two groups. So just from that data alone, you can see that the UK has got one of the larger employment gaps, if you like, or health employment gaps. That's the gap between the bar and the diamond. Having said that, it's a bit more complex than that might suggest, because these are fairly raw data, so we may not be necessarily comparing like with like. There could be population differences that help explain the differences between countries here. So, for example, if you're looking among older populations, people with long-term ill health would be more likely to drop out of work. And then you've got other things like education level that can also come into play. So what we do next in our analysis is multivariate analysis, where we're controlling for some of those demographic differences. So we're comparing like with like. And then what we do is we calculate what's called marginal effects, so that we're isolating the impact of country. And what that analysis looks like is this. So immediately you can see that the UK is still at the higher end, although some countries are doing worse than the UK, so in particular Belgium. What this graph shows is that in 2022, for example, comparing like with like, UK adults were 19% more likely to be out of work if they had ill health than if compared to if they didn't have ill health. And that got slightly worse over the pandemic for the UK, so comparing the green and the orange bars. But you can also see that for some countries, it improved in the same period. So in particular, if you look at the countries lower down in the graph. So for example, if you take Italy, there in the middle, you can see that if you can look at the orange bar for Italy, it was about the same level as the UK in 2018, but it improved a lot in 2022. So that's saying that the people with ill health were less likely to be falling out of work. So that's for the working age population as a whole. And what we also do is we look at how it differs for different age groups. So for older workers, first of all, we see a similar looking trend overall, but in general, they're more likely to be out of work if they have ill health. One thing that I think to notice, though, in this graph is that basically the UK is kind of going in the wrong direction. So 12 of the EU 15 countries improved in the employment outcomes of this group, older workers or older people with ill health. But for the UK, it's one of the few countries where it got worse in the same period. Among younger workers, it gets a bit more complicated because we've got a few countries on the left in the negative. So this is showing that historically, young people were actually more likely to be in work if they had long-term ill health than if they didn't. And that's something that perhaps we can talk about later. But what I really want to focus on as the headline findings, and is quite worrying for the UK, is that we've gone from kind of middling to bad, or even middling to worst. So young people with ill health, so this is at the top of the graph here, young people with ill health were 6% more likely to be out of work pre-COVID, but more than double that afterwards. And that is, as you can see, that's by the 2022 data, worst in the EU. So a few conclusions. The UK has one of the higher rates of long-term ill health among the EU 15. It's also one of the largest employment gaps for ill health. And the situation has worsened post-pandemic. So for young people, they're the most likely to be out of work within the EU 15. And for older people, it's got slightly worse, whereas for other countries, they've managed to improve. So I think that it's clear that the UK situation is worse than it needs to be. It doesn't have to be this way. Ill health could have a much smaller impact on employment than it currently does in the UK. And we should really start here if we want to address economic inactivity. And I think it's really about finding the right combinations of support and incentives so that people will be more likely to stay in work or to move into work, even if they have ill health. So I'm going to leave it there and hand back to Anita.
Thank you so much for that very clear and salutary presentation, Johnny. So we're now going to move into the panel respondents, and we're going to start that with some remarks from the OECD. I'm delighted to be joined by Christopher Prince, who is Senior Policy Analyst at the OECD, working in the Directorate for Employment, Labour and Social Affairs. Joined the OECD 20 years ago and has been responsible for the organisation's work on the links between health, sickness, disability and the labour market. It's fair to say that John has been very prolific and is the author of more than 30 OECD books and publications, including on integrated mental health skills and work policy. So Christopher, really interested to hear your reflections and insights. Thank you.
Good afternoon. Thank you, Anita, for the kind introduction, and thank you to the organizers for inviting me to this seminar. What I really enjoy a lot is that the seminar will be built very much on the questions from the audience. So we only have a few minutes to introduce a few thoughts, but actually I think much of the seminar will be carried by the questions that you will be posing to us. And with that, since we have only a few minutes, I just wanted to bring into the discussion two big themes, which I think are particularly important for the United Kingdom. The first one, I would maybe call it something like policy volatility. I think the starting point for me when I look at the UK is if I talk to experts and policymakers, there's a better understanding and a better discussion on the whole issue of health and work than in any other OECD country. So I really feel like in many ways the UK is a vanguard, is very advanced in its thinking. If you look at the green papers and white papers that have been prepared over the years, very impressive, lots of knowledge put together, lots of good suggestions on where and how policy should change. But here comes the downside. Despite all of that, the impact is impressively limited. So the question, of course, is how come that such good understanding of what should be done is not translating into better policies and better outcomes? And I feel there's a couple of explanations here which we need to go into while discussing. One, of course, is very simple. Maybe all these nice ideas actually are not implemented. Of course, then they can't have an impact. Often they are implemented a little bit, but very poorly. There might be all kinds of pilots. They seem to be running well, but maybe actually policies are never rolled out, or once they're rolled out, they're not rolled out in the way that the policy was initially meant to be. So in a way, there's a real gap between the idea and the actual implementation. And an additional element here is that the policy in the UK is changed at a speed that it's very difficult for such a complex field as sickness and disability policy to actually let new ideas unfold their impact. So it feels like, I mean, just look at the frequency with which the benefits that are available are being renamed, sometimes with the intention to give them a different purpose and have a different requirement and process in place. Often things change so quickly that they can actually not really implement the real and unfold their impact, right? So and there's so many examples. Like, just think of the fit note, which was introduced many years ago. An excellent idea, definitely the right idea to move away from a sick note to a fit note. A few years later, initial evaluation suggests this hasn't really ever been properly used by a doctor, and more or less the idea disappears and it vanishes. We keep emphasizing this as good practice and an important step to take for other countries, but it seems like the UK itself has not been able to implement that a good idea. There has been so much good thinking about occupational health and policies needed, especially for SMEs, to unfold a good occupational health policy. It has never really been implemented. At best, maybe some online web lines have become available, but policy has not really been put in place. And I think a lot of the explanation behind all of that is, despite good intentions, the UK has never actually taken the guts to invest as much into all these systems and policies as would be needed. So it's in a way, the weak public policy explains why these ideas have not ever succeeded. And I think from the point of view of an analyst at the OECD, the UK is a fantastic laboratory because there's lots of policies that are being innovated and invented and tested, so we can recommend this to other countries, which sometimes actually implement things successfully. But the UK itself has not really lived up to the potential it has developed itself. And the second aspect that I wanted to bring into discussion is what I believe is the single biggest problem in the United Kingdom, and that is the lack of early intervention. I think there's also a lack of prevention, but that's very common across the OECD. I think countries generally struggle with having preventive rather than reactive policies. But I think the lack of early intervention is even more when people get sick, is even more important for the UK. So, as I said before, the UK has gone, for instance, to all kinds of changes of its benefit system with many new ways of structuring and defining entitlement for benefits, and including often a change in the work capacity assessment. But early intervention itself has never really come into play. It is still what the approach towards sickness and disability is in the UK. Basically, people still move on to some sort of disability payment relatively quickly and easily compared to other countries. And the idea to provide support for them to stay or return to the labor market is only brought into once they are on a disability payment. And this is completely the wrong sequence. We know from research across the OECD, if someone is receiving a disability payment, there's no way these people would ever move off this payment again. So in a way, a policy that is built on let first people move on to disability payment, and then we put in all kinds of measures and tools to help them move into the labor market is just completely the wrong way around. Instead, we should invest much earlier, much more in the beginning phase, in particular in the first few months of a sickness spell, because that's when we can really make a difference by better tools, better measures, better ways to help people stay in the labor market. So in a way, the moment people have turned to applying for disability payment, we have lost them to the labor market. They have more or less decided that, well, this labor market is not for me. The labor market is not offering the type of employment that I can do or want to do. And in that sense, this is simply too late. So just two examples, right? There's a total lack of medical and vocational rehabilitation at an earlier phase, which is what some other countries are focused on very much, where it's almost impossible to get onto a disability payment without all these other tools having been tested, whether they could possibly help them stay or return to the labor market. And I think the reforms of work capacity assessments, which is also, as I said, very exemplary in the UK, because they have tried really with good intention. They're a little bit in line with that, because basically what the UK just did is trying to disentangle those who should be receiving a disability payment from those who should not, rather than actually helping everyone to stay and return to the labor market. So it's rather more like trying to identify who are the deserving, who should really be on a disability payment. Ideally, you could say, well, maybe then this is those who we believe should stay there forever and not necessarily have to move off. But the UK has struggled with that. And now we see again disability claims and numbers rising, because simple this distinction of who is and who is not able to work is not easy to be made. We should actually invest into tools to help them back to the labor market, irrespective of that question. So in a way, again, example of how the sequence is turned around, and we should indeed focus on early intervention in all possible ways. And I'm happy to discuss during the seminar what this could mean and what other countries are doing. Thank you.
Thank you very much, Christopher, for those excellent insights. So next, delighted to have a contribution from Sarah Cunningham. Sarah joined the World Wellbeing Movement as its first managing director in June 2022, having had 25 years experience in strategy, marketing and organizational leadership in a number of leading companies, including MasterCard, Google, BT, Capgemini and Accenture. I was incorrect in saying that they're based in Ireland. They're not, they're based at Oxford, where they're located with an academic partner, the Wellbeing Research Centre at the University of Oxford. And I think really interestingly here, in addition to the World Wellbeing Movement work, Sarah's also been doing a lot of work around the role of women in business, and in particular in IT. So that's fantastic. So Sarah, over to you for your reflections.
Thank you very much, Anita. And thank you, Johnny, for a very insightful data-driven presentation. We've talked a lot about the role of policy, and I will touch on that, but I also want to talk a little bit about the role of companies when it comes to prevention of employee ill health, and also supporting employees with long-term health conditions to try and close the employment gap for employees with long-term health conditions. We at the World Wellbeing Movement, we're very focused on taking an evidence-informed approach. So certainly the report is very much after our heart. So in that vein, the first recommendation I suppose I would make is the importance of employers, companies measuring employee well-being. And one of the things we always say is that it's important not only to measure how employees are feeling, but also to measure why they're feeling that way. Starting, of course, with measuring how employees are feeling. We have recommendations on our website, the World Wellbeing Movement website, for using science-based measures to measure that. We do believe policy should play a role here. We do believe that actually employers should measure employee well-being just as they've been measuring, gender pay gap, etc. But don't stop at just how employees are feeling, because there are so many drivers of our well-being at work, whether that be sense of belonging and inclusion, flexibility, trust, manager support, the list goes on. And we always say, analyze those drivers once you've measured them. So if you look at a particular group, like say, for instance, older workers, and the data is showing you that actually older workers are struggling to feel a sense of belonging in the workplace, or to achieve the flexibility that they strive for, or perhaps with unachievable job demands, the next thing I would say to employers is to listen, run focus groups with people within this demographic and hear from them, because you may find why people from that demographic are leaving the company, or perhaps, just as importantly, what's preventing other people in that demographic from joining the company. So measure what you treasure, as we always say. For companies, I suppose the next thing is crafting your employee well-being strategy off the back of that measurement. And I always say that you cannot treat well-being in isolation. You've got to take a holistic approach, and your well-being benefits have got to align with your workplace culture. So if as a company you talk about being a flexible company, but actually you're insisting that all workers come back on, 2 days a week into the office on a Tuesday and Wednesday, well, that may well be prohibitive to people living with long-term health conditions. And of course, there's many other examples. So really ensuring that your well-being benefits align with company culture. And I think the third point that I would make is the importance of investing in evidence-based interventions. And again, what's so great about this report is it is an evidence-based report, albeit the findings are alarming. But we at the World Wellbeing Movement have published the Work Wellbeing Playbook, along with our academic partner, the Wellbeing Research Centre at the University of Oxford. So we conducted a large-scale systematic literature review where we looked at interventions that are proven to improve one of 12 drivers of employee well-being. And we have published that. It is really important that companies look at what actually works to improve employee well-being, and look at the drivers of employee well-being that need to be improved at your own companies. it's no longer about rolling out those sort of trendy work well-being initiatives that maybe don't have any evidence base behind them, but rather looking at what really works. So that's sort of a whistle-stop view of my thoughts here. Policy certainly has a role to play as well, and I might finish with the fact that in the UK, obviously, the employment rights bill has been debated in the UK at the moment. We believe that's missing measurement of employee well-being, and we believe that will be a really good addition to that. Thank you.
Thank you so much there, Sarah. And our final panelist is Mette van Vilsteren, who is Senior Knowledge Advisor at the Dutch Employee Insurance Agency, and really thrilled that you're able to be here because a lot of policy interest in the experience in the Netherlands. Mette is the Senior Knowledge Advisor at the Strategic Policy and Knowledge Department at the Dutch Employee Insurance Agency in Amsterdam. Her research interests are in the areas of promoting work participation for people with disabilities and the prevention of work disability. And Mette holds degrees in health sciences, epidemiology, and PhD in social medicine. My goodness. So over to you.
Thank you, Anita, and thank you all for having me. As Anita mentioned, I'm calling in from Amsterdam. I work at the Dutch Employee Insurance Agency. We are a public organization. We help people who are out of work or who are unable to work. We provide benefits and help people and support people to get back to work. Well, first of all, I think it's really interesting and important to look at how others or other countries deal with the problems I think we all face. Last year, I performed an international inventory of work disability systems in 8 European countries, including the UK, which gave us useful insights in how other countries set up their work disability systems. I would like to mention, though, that there is no ideal work disability system. Every system has their pros and cons, as well as our system in the Netherlands. But today, the organizing committee invited me and asked me to give you some more insight into the Dutch system, and more specifically, a reform that we had, a reform that was effectuated in 2002. So I will tell you a bit more about that. In the Netherlands, if an employee on a fixed contract calls in sick, the employer is responsible for the first 2 years of sickness absence. That means that the employer pays the wage of that employee for 2 full years. And furthermore, the employer is responsible for the reintegration efforts. That means that the employer, the employee, and an occupational health service work together to make a plan for returning back to work. This plan can include anything from a gradual increase in hours to any adjustments at work, or even to return to work in another position at the firm or a position in a different firm. The employee and the employer have to prove that they've tried everything to get the employee back into work in order to be eligible to apply for a work disability pension. The system I've just described only counts for employees on a fixed contract. Workers on a temporary contract, for example, will apply for a sickness benefit at the Dutch Employee Insurance Agency. The agency, so we provide them their income and work with them on returning back to work. We see, however, that a significantly higher proportion of these workers end up in a work disability pension when compared with workers on a fixed contract who worked with their employer on returning back to work. So the involvement of the employer for us is a really important measure. So that's basically our system, and I will leave it at that. And yeah, I will be open for questions.
Brilliant. Thank you so much. So you've all responded to my request to get active on the Q&A, and there are lots and lots of questions. So the way I'm going to organise this, if it's all right, is there are a number of questions specifically about the analysis, which has generated a lot of interest. So I'm going to start by playing some of those questions back and giving Johnny an opportunity to expand on that. But then there are a number of observations and questions related to some of the implications of that and what's going on in other countries moving into the policy sphere. So then I'll come to the wider panel for those as well. But just, Johnny, starting out, one of the questions that people are asking about is whether or not you've presented the national aggregate data. You've obviously shown the difference between younger workers and older workers, but whether there is more disaggregation here. So people are interested in particular, I mean, I guess with a nod towards some of the policy and explanation is, you know, is this pretty consistent, or do we see a geographical pattern linked to deprived areas? Similarly, another domain of diversity, we're seeing different pictures by ethnicity as well. So can you talk a bit initially to the extent to which we are able to, and you've been able to unpack this below the national level and look at some of those different groups in the population?
Yeah, certainly. It's obviously a really important question. What we've got with our analysis so far, I would say it takes us pretty close to isolating the country effects. So the difference that being in one country compared to being in another country, most demographic things being equal, what difference that country makes. And what we've controlled for what we felt that we could, but there are other contextual factors that are harder to disentangle. So one of those would be the policy differences, but also you've got other country specifics, sort of socio-cultural differences that aren't just a simple reflection of demographics. So it's difficult. Much of the differences that we see is likely to be influenced by policy. We can't say how much from the analysis that we've done, but what we can do is to look at the impact and process evaluations that exist of specific policy interventions. And we can see, we discussed this in the second part of the report to some extent, so we can see that there are some interventions that do make a difference. So I'd very much echo what Sarah says there about the need for that evidence-based approach, because in a sense, if you're focused on policy, that's your next best step, is to look at the specific evaluations that have been done. And what else? You talked about sort of deprived areas and ethnicity. So the controls that we've looked at included sex, age, marital status, and education. So there's certain indicators of social deprivation that we don't have there. Education would be one thing that's influenced. And we don't have ethnicity there as well. You know, there could be more things that we were taking into account. I also noticed that there was a question about occupations, which I think is a really interesting area, because we know that occupational differences explain so much in terms of job quality outcomes. And kind of similarly to occupational differences, the kind of employee relations differences, like, are you on a fixed term or a permanent contract? Are you a manager or not? These are things which are really, really influential. So we haven't done that within this analysis, but that would be like a next step to sort of delve a bit more into the data.
Yeah, and I guess there are a number of questions then, and we heard from panelists really interesting perspectives on different examples that in the work and in the analysis here, looking at the very different performance of different countries, countries differ by the structure of their labour markets, which you've just alluded to, by their benefits and social security systems, by the active labour, the type of approach they take to active labour market policies, etc. Are you able to say anything to this work about the kind of relative contribution if we're thinking about where the UK might target? And you know, Christopher was saying to us, we're almost awash with policy within the UK. So focus, focus, focus. Pick a few things, do them well. Maybe I'm paraphrasing him, but you know, pick a few things, do them well, do them in a sustained. Does your research here give us any indications of where, if you like, we should focus there based on other countries that are doing better than us?
There isn't a simple answer to this. I really don't think. I think that we need to start delving into some of the specifics, the nuts and the bolts of what policies and what different interventions are happening within the country, also what the contexts of that countries are. So one thing that comes out in some of these graphs, the UK looks at sometimes a bit similar to countries like Italy, for example. So but then at a basic level, we've got quite a different approach to policy. Italy much more proactive in its policy than the UK, but we can't simply say, therefore, we should do what's happening in Italy. When we look at what's happening in Italy in terms of the data, it's a real mixed picture in terms of the levels of ill health and the employment outcomes. So we need to start getting a richer picture of what's happening in Italy on the ground, what's happening in the Netherlands, Germany, and we need to take that more detailed point of view, I think, is the next step.
Brilliant. On that point, I'm going to bring in other colleagues on the panel. So there are a number of questions that are really asking, why is it that the UK has got so much worse? And what is it that some of the countries that have got better and are performing better are doing? And so interesting to hear any panelists who wants to come in on that, and perhaps with that OECD overview. Christopher, I might ask you first of all if you've got a perspective on that.
Thanks, Anita. I must admit, I also discovered a couple of interesting questions that I don't know whether I'm free to just pick some from the chat that I think is important to answer to. Well, they're all really relevant, but of course, a lot go beyond the scope of this discussion here. I think, and I wanted to, maybe before going to yours, I just wanted to quickly to talk to some of those. Like, I think a lot of them can be summarized under the question, how strong are the institutions in the UK to actually take any of the roles that other countries are able to give to their institutions. And one example, there were quite a few references to the unemployed, the long-term unemployed with health issues, and the extent to which the unemployment system actually takes care. I think that's another very important aspect of early intervention, that the unemployment system very much understands that it has in particular an obligation to help people with health conditions as well. People having health as an additional barrier to the labor market. And I think that's a good example where the institutions in the UK are simply too weak to really take that role. The public employment service is not considered a service that anyone would really choose to go to. In other countries, the public employment service is a place to go, even for employers, actually. So in many ways, actually, employment services in some countries are also having a preventive role, helping workers to change jobs when they've realized I'm maybe not in the best job, which eventually might prevent sickness and longer term labor market exit. There were questions related to the health system and NHS, right? I think NHS has a lot of strengths. I would really be careful in hitting too much on it. I think the issue of waiting lists, which are here in the UK all the time, is not worse than in other countries, and maybe in some pockets. Yes, I don't know how much the regional difference matters in the UK, but I think the UK generally has a reasonably strong health system. I don't think that is the cause of everything. More than any other country, actually, the NHS tries to talk about waiting lists and set targets for reducing waiting lists. In many other countries, this is a non-issue, and we have no clue how long a waiting list is. That brings me to mental health, which has also been addressed by a couple of the people in the chat, where I think there's many issues around that. There was also a link to the question about the education system. I think particularly for mental health, the education system plays a very important role, because we know that mental health issues arise in childhood and youth and not just as an adult. So, and these childhood and youth issues actually drive what is happening later in life. Mental health issues might be triggered eventually by something happening at work, but the truth is it's always a combination of long-term experiences in your life and something happening at work. So it's rarely ever caused by work per se. So in that sense, yes, the education system is another important institution where we can do better. And another issue was around incentives for different stakeholders. And we should not just talk about incentives for workers. I think that's actually maybe the least important. Much more important is to talk about incentives for different stakeholders and institutions. And in reference to the footnote, for instance, yes, if there's no incentive for a doctor to implement that properly, we won't get anywhere. So it has to be strong guidelines which are strictly followed and supervised, and ideally coupled with incentives, right? So I think in that sense, I think that's an issue where many countries struggle, that actually the public authorities also have responsibilities and therefore need better incentives to actually live up to the new tasks that we want to give them. I've not referred to any single country. I know I'll do this later, but want to leave the space for the others, please.
Brilliant. So, Berta and Sarah, there are questions in the Q&A, both about how this works and good practice for SMEs, yeah, and also this issue about, I guess, a lot of the burden of ill health that we're talking about here being mental health and musculoskeletal problems, and best practice, I guess, around those two issues from the international experience. And I wonder if you'd like to come in at all on both, you know, how the role of SMEs, and in particular, I guess, the mental health, and most perhaps both of you as well, this issue of the young people is something that is very interesting that Christopher just picked up on.
Well, just to clarify, what is an SME? I'm sorry.
A small and medium-sized enterprise, so smaller companies rather than the big companies.
Okay, and the question is how they deal with employees with mental health issues,
and the whole issue of ensuring that workers and potential workers with ill health are able to work. So sometimes what people say here is that big companies can do this because they have dedicated HR, they can cope if people are away, but this is very challenging for small companies, small organizations, to be able to deal with it. And so some of the criticism sometimes is that the policy measures that are put in place will work for large organizations, but not really relevant for SMEs. Smaller,
yes.
Sorry. Smaller organizations.
Okay. I understand now what it means. I think we struggle with the same things. We also see a huge increase in people coming into our disability pensions with a mental illness. And it's especially hard for the smaller companies. We have the same issues. What we try to do is work with the employers on prevention. So we try to see what prognostic factors there are, and also implement interventions to reduce stress at the workplace. So that's what we do, and we also support workers who are trying to get back into work with mental illnesses, for example, by preparing with them what they need from the employer in order to be able to work. So that's a big thing we work on, to help them also communicate with their employer. You know, this is what I can do. This is what I need from you, so that they will be more able to work.
Yeah, and I might just build on that quickly, if I may. And I do see that one of the questions that came through was around psychosocial risk assessments. I think when it comes to mental health, really policy has got a strong role to play here as well. And that's looking at the evolution of occupational health and safety. A lot of the really brilliant health and safety regulations that we see in play were probably born in the Industrial Revolution and are for the most part more relevant to our sort of physical safety. But the reality is many fewer of us now work in sort of factory settings where, you know, we have hazards to our physical health, and actually very often the hazard is to, you know, mental health, such as stress, burnout, etc. So looking at what other countries have done well, obviously in the UK, the Health and Safety Executive, it does provide guidelines around conducting psychosocial risk assessments, but actually Australia has been very effective in this regard, with clear, sort of strict and more proactive code of practice around psychosocial hazards in the workplace, and also actually explicitly requiring that employers, you know, respond to that and their sort of enforceable standards. I mentioned as well when I spoke the importance of measuring employee well-being. You know, again, policy has a role to play there, but measurement is only part of the puzzle, and actually having an action plan to go along with that measurement makes a real difference. And again, learning from other countries, this is something that Iceland did quite well when it came to the Gender Pay Information Act, which is that companies were not required to simply measure the gender pay gap, but actually also publish action plans on what they're going to do to address it. So definitely there's a strong role for policy. I think with SMEs, all of the points that you mentioned, Anita, are very real challenges. You know, some of the larger companies, as you say, will have bigger budgets, could hire, for example, you know, an expert in workplace well-being that actually a small to medium-sized company may not be able to. That's one of the reasons that we're trying, that we are a charity at the World Wellbeing Movement. So all of the thought leadership we publish is open access, and it's available to anybody. So if there is anybody listening from a small to medium business, you can access, you know, our Work Wellbeing Playbook and webinars on that anywhere on our website. But one of the things I always say is that improving workplace well-being and crafting a strong work well-being strategy, it is certainly not one and done. It's measurement, analysing that data, talking to employees, listening, looking at the drivers of well-being that are really impacting people, rolling out evidence-informed interventions aimed at improving those drivers, and iterating, because this is an iterative process.
Thank you so much. There are a number of questions about early intervention, both, and I think, Christopher, you emphasised, and Vicky Belt has made this point, that many of the other countries that seem to be doing better are more focused on keeping people in employment and early intervention. So there are two questions linked to early intervention, and I'll invite all four members of the panel to comment on this. The first is, well, what does good early intervention kind of look like? What do we know from the evidence works? And the second thing is, if early intervention is so important and taking that preventative approach, how do we incentivize companies to do that? And is this something that there is a clear investment benefit, or do we need other measures like regulation, etc., to make that happen? So I'll come to everybody. Let's start with you, Christopher, then, because you flagged it. Then I'll go to Johnny, and then come to Sarah and Mercer, if that's okay.
Thank you, Anita. I think, again, also this question is particularly important for SMEs. I think generally this is where public policy is needed, right? Large companies can do much of that themselves. So for them, regulations and frameworks and incentives will be sufficient. But for smaller companies, we really need a support system in place. And in that sense, I think just quickly before now say a few words about other countries, someone in the chat also referred to the review by Carol Black, which was, I think, 2008, which is ages ago. The whole idea was to implement a system that is actually there to help SMEs do what other larger companies could do themselves, except it wasn't done. And with that, that brings me to an example, sorry, from Austria, where they have introduced something which they call a fit to work service, which is exactly meant for workers who are on sick leave, and for employers, even possibly before their workers are on sick leave, to seek help and get the help that is needed. Basically have an institution to go to ask, this is the situation, this is what the situation we are facing, what can we do? What can we do before the person drops out? And I think that's more or less what Carol Plack had suggested to implement, except that it wasn't done. Another example from Switzerland, maybe also an interesting example, because in Switzerland, it was also the disability insurance, which was facing a large increase in number of people on those benefits, realized that there's no other institution in place that does anything in terms of early intervention. So it was that insurance itself that decided to put in place new ways for employers to get support directly from the last resort institution, which eventually pays if someone has really dropped out of work. So they realized if we want to reduce these numbers, we need to start helping employers. So the basic idea was that the employer can turn to the disability insurance when they feel there is a risk that someone could possibly drop out of the labor market. Maybe when they see there's someone having repeat sickness absences and they don't understand why. So it was actually essentially putting in place an algorithm or a possibility to seek help very early on. And then at the same time, they introduced what they called very low threshold early intervention measures that would actually be a decent response at that stage of the problem. And it had really helped reducing new sickness and disability benefit claims and reducing those who permanently dropped out of the labor market.
So I could pick up from there. I think Chris gives a really good full answer regarding incentives. I think one of the things that strikes me in the literature that we reviewed about incentives is that it's not enough sometimes just simply to have them. They need to be implemented in the same way. So to give an example, and perhaps Mirte can add to this. There's a program of incentives for employers to invest in ill health prevention in the Netherlands, and the experience there was that they worked, but they only really worked when employers started getting involved, or employers were started to be allowed to be involved in decision-making processes around how they worked, the mechanics and the nuts and bolts, and so on. So we do have at one level certain types of interventions that can have an impact, but we need to think about how they're implemented. And I think building on that, one of the things I would say, it's not enough for us just to look at examples of policy and to think what works or what from the evidence that we have seems likely to work. I think we also need to be considering what's likely to fly in the UK. So we've got, for example, in our review, examples of quotas being used. I mean, I think it's pretty unlikely that that's going to be adopted in the UK. And possibly too, things like stronger duties on employers to have occupational health services. Maybe that's going to be too much of a push on too much of a demand on employers in the current climate. So I think we really need to think about what's likely to work, what's going to be realistic for the UK to adopt. And in one sense, I think that brings us back to Chris's earlier comment, which I'd say is a really well-made one, that it may be less a question about introducing new interventions, getting more evidence on what works. It may be more a question that we need to follow through on the evidence that we've got. And I think just one final thing about incentives that I would say is, if we're trying to work out when an incentive is appropriate or not, I think that the key thing is where there isn't an actual incentive, or there are just barriers to employers adopting it. So, for example, if budgets are very small and you're working with SMEs, as has already been mentioned, but we need to look at what that gap is that's going to get in the way of employers and indeed other actors in adopting these practices.
Yeah, Johnny, just picking up on a lot of good stuff you've said there, and yeah, absolutely, context matters, as you say. So when it comes to the evidence base, looking at, culturally, will that be appropriate for, for the UK? I do think it's important to mention that obviously policy has a key role to play, but there really is an existing incentive for all business owners to do more and put more evidence-based interventions in place to support the well-being of their employees. So there's a very strong business case now that shows that, first of all, happier employees are more productive. There's also some really great research that talks about obviously talent attraction and retention. And Johnny, of course, that's what, a big thing that your presentation showed us was that very sadly, so much really strong talent is feeling left out of the workforce at the moment. So that brings up the importance of diversity, and we know there's all sorts of statistics around the positive business impact of having a truly diverse workforce. But there was a really important piece of research done, which actually shows that companies that have the highest work well-being scores perform better when it comes to financial bottom line returns, and for the stock listed ones, also in terms of stock market returns. So there is a very strong business case and incentive for all business leaders. And I would argue that actually a focus on crafting an employee well-being strategy that's evidence-based is as important as the overall organizational strategy.
Yes, just to add a couple of things from the Netherlands. I think when it comes to incentives, as I described, Dutch employers have to pay the wage for someone who is sick for 2 years. So they have a huge incentive to get them back to work. But what we've seen in recent years is that there's more and more focus on prevention of sickness absence. And employers in the Netherlands are affiliated with an occupational health service, whether they are small or large businesses, and that helps them tremendously because the occupational health service do some sort of like a risk inventory in every company. So they visit the company and see, what risks are these employees what risks do they face at the work floor, and what puts them at risk for sickness absence, and what can we do to prevent that. And also, if you are an employee and you do not feel well at the workplace and you think it's not going well, I might be getting sick, you can also preventively visit the occupational health service and seek help. So we see a focus more and more on prevention of sickness absence.
Brilliant, thank you. And that leads me into a number of the questions, picking up in part on the discussion of some of the recommendations of Carol Black's work, but also then, Christopher, what you were saying about the effectiveness of implementation, are raising questions about what's the role of the health system versus the employment system versus the sort of employers, and the skills and balance between those. So have we got that mix right? Are there some lessons from the international literature about who leads, who does what, and how you do that effectively? Because as a number of the questions have been asking, we've tried various things there with mixed success. So I might ask Christopher and Johnny to start that, but then Sarah, to bring you in with any insights as well from other countries where you feel they've got this balance between agencies working well.
Thank you, Anita. I'm happy to come in. I'm sorry, I'm always referring to the chat myself as well. I did see, and I thought I really want to emphasize that again, because there was quite a few comments in the chat suggesting that the recommendations from Carol Black were implemented. And it's very interesting that you think so, and several of you think so, because the reality is they were not. the only thing they have implemented was some sort of helpline where you could get some advice where you could possibly turn. But the idea of Carol Black was to implement a new service where you can go. But I think it quickly turned out, well, that would cost 100 times more what the government was willing to invest, right? Which linked me to the very first questions I've seen were all related to the deadweight cost of an early intervention approach, right? I think that's a good example. UK is so worried about deadweight cost that they better don't do anything. I think, yes, we need a totally tailored individual approach, but to get there, some deadweight cost might be worth it actually to identify what really works for whom. But now to your question on the balance between health and employment, I think that's maybe one of the most critical questions, right? Especially health systems work in silos usually and are very poorly connected with the social and the employment system. And I think we all know what we really need for people with multiple challenges, including employment, social and health barriers to employment. They need integrated service at the same time, right? And I think a lot of countries and systems struggle because they will suggest, well, first go to the health system, and once you are fully fit again, you come and we help you with other problems. The key issue is we need to do this all at the same time. So ideally, we would want these systems to work hand in hand. But I think a second best solution also is, because we know that this is not really easy to achieve, that within each system, we provide integrated services. And I think, again, the UK was in principle a good example because they realized, well, we need to provide employment service together with our health service. So it was actually within the health system that they started to hire employment advisors linked directly with the health services that are provided. So I think that's probably the way to go. Have all the different options within the different systems. Again, probably the first thought of some of you would be, well, are we not creating deadweight costs if suddenly the health sector tries to develop its own employment services? That's not what it is, right? Wherever a person turns to first, is it the health system or the employment system, they get integrated service. They're not going to both to get integrated service twice. It's just important that they quickly get both, irrespective of where they enter into our system.
Yeah, thanks, Chris. We in the report we drew on this typology, conveniently labelled Type A and Type B, with Type A countries having a more systemic approach, so a single framework, bringing together the different health employment systems and so on, and also having clearer responsibilities mapped out for the different actors, for employers, for government, and so on. And I think that this is something that comes through, it's quite palpable in a lot of the evidence that we're looking at, certainly in what policies exist. So those Type A countries include sort of the likes of Netherlands, Finland, Germany, but also other countries, Japan, France, Italy. And then the other alternative is countries like the UK, where legislation is a bit less clearly defined, it's more dispersed, and more is left to the market. So for employers to respond to the market, they've got certain duties, and then it's for the market relationships to kind of pick that up. So as well as the UK, you've got Canada, Australia, and Ireland, which sort of have those systems. And there is, I think, some sense in which those, because we're talking about subjects which is a kind of, it's a complex systems question. So it's not surprising, I think, that there are examples where those kind of Type A countries seem to do better. But having said that, that's clearly not something that you can change overnight. So I think a critical question for us is, given that we are one of those countries that don't have those kinds of that systemic approach overall, what can we do? And it's a bit more, it's like, given where we're at, where can we make improvements, I would say.
Brilliant. And Mercy, is there anything from the Netherlands that you would want to add about how the different agencies work together?
Yeah, well, in the Netherlands, the curative health system and work-related health, work-related care are also two separate domains, and they do not routinely work together. We struggle with that as well, so I recognize what you're all saying, and I agree with Christopher that it should be integrated. It's much more easy for the patient or the client as well, but we struggle with that as well. I think now exchange between the two is possible after consent of the employee, but it's not a standard procedure, and we're seeing if we can change that, but it's a difficult change.
Thank you. Excellent. So we're almost at the end of the webinar. So I just wanted now to offer all of the panelists an opportunity for some final closing remarks. So Johnny, come to you first, and then Sarah, and then Mette, and then end with you, Christopher, if that's okay.
Thank you. It's interesting seeing some of the questions coming through, and not surprisingly, I suppose, in one respect, lots of questions following on, asking for more detail on the analysis. There is clearly a lot more analysis that we could do here. In one sense, we kind of just scratched the surface. But I think within the bounds of this project, what I hope that we've done is offered quite a powerful provocation, which is to say, the UK is clearly not doing well compared to other countries, and it doesn't need to be this way. There are things that we can do. What exactly we do, what we can attribute, what differences we can attribute to which causes, we need to look further into that. But I think the key thing for me is we can and we should be doing more to improve the employment outcomes of people with long-term ill health or disabilities.
Brilliant. Thank you. Sarah?
Yeah, thank you. And thank you again for all of the insights in the report. It certainly was a powerful report. And I think, the reflections for me are really just reiterating that the incentive is there, that if we can, improve employee well-being, which plays a big role in prevention as well, we can improve business results. And that really, I suppose my key takeaway is, when it comes to workplace well-being, it's not a box-ticking exercise. There is no secret, and it's not marketing. This should be evidence-based. So measure employee well-being, take a holistic approach, and avoid the trendy well-being initiatives that actually have no evidence base behind them.
Brilliant. Thank you. Mette?
Yeah, I just want to say thank you for having me. I think it's great and really important that we exchange our experiences and that we can learn from each other, because we all have our struggles. We do as well. And this is very useful. Thank you.
Thank you. Christopher?
Just a minute, as I know we are still having one statement in the next few minutes. I think it's important that the UK moves away from just thinking about incentives for workers to actually helping and providing the right support. And I think we know that the UK benefit system is very not generous, right? And despite the benefits are so ungenerous, you have the problem that there's people moving onto it too easily, right? So it tells you something they really need help, and maybe we are just providing the wrong type of help. Thank you.
Thank you. Well, that is a great thought, I think, to bring us to a close. So it just wants me to say that I think, to Johnny's point, the report really highlights what I think policymakers are enormously aware of, which is this is a really important and pressing issue. We think it is, which is why we've set up the Health and Work Commission, and benefiting from the insights of some amazing people, including Dame Carol Black, with a lot of expertise in this area. Although, as I think the international examples have shown today, actually this is a complex issue. People's health is complex. There are, as the questions and the comments have shown, there's really strong interactions with psychosocial and economic context that people live in, and multi-agency responses with all parts of civil society playing their part are almost certainly critical to this, and everyone finds that hard. Integrating policy making, integrated service delivery is hard, but actually, as Johnny's work shows, we can do better. Even though it's hard, we can do better. We are bringing our commission to its conclusion, and in the early spring they will be setting out their thoughts and contributions on this, helping, I think, to show how we can move forward and make meaningful change. Please do look at the research that Johnny has talked us through in Headline today. It's absolutely fascinating and really valuable. You can find it on the Health and Work Commission website, but also on the IES website as well. If you'd like to stay in touch with the work of the Commission, then do sign up for updates via the chat. And if you'd like to listen back to any of this, or please share it with your friends and family, the webinar recording will be available in 24 hours' time. Thank you so much. 100 questions, more than 100 questions. I am really sorry if I didn't do justice to those. And it was, I thought we had loads of time and we've run out. So I'm so sorry. That's because it's a fantastic topic. You've been so engaged. We've had great speakers who have been brilliant. Thank you so much, everybody. Enjoy the rest of your day and look out for the final recommendations of the Commission in the spring. Bye-bye, and thank you so much.